Ladies and gentlemen, welcome to Parasitology. Before we start with our discussion, we will be having a pre-test. Let's test your knowledge. Please note, you only have 10 seconds to answer each question. Good luck! He founded the parasite trypanosomes in Trimatid bog. Your time is up. The correct answer is Carlos Chagas. It is a causative agent of Chagas disease. Time's up. The correct answer is Trypanosoma cruzi. What causes the chronic human African trypanosomiasis? Time's up. The correct answer is Trypanosoma bruchigambins, also known as the Old World subgenera of Leishmania species. Time's up. The correct answer is phlebotomist. It serves as a primary reservoir of Leishmania species in urban areas. Time's up. The correct answer is dogs. He identified Leishmania brasiliensis in 1991. Time's up. The correct answer is Gaspar Viana. Good job. Now, let's begin with our discussion.
All right, thank you very much for that pre-test. So, by the way, let me introduce myself. My name is Lloyd Martin Mataverde, and good day to all of you guys. I do apologize because I'm not feeling well, so as you can observe in my voice, so it's a bit husky. All right, so for today, we'll be tackling about Trypanosoma cruzi. Okay. All right, so since this is a wonderful day, so basically I'll be giving you a table of contents for my report for today. All right, so number one, this table of contents will also serve as our learning outcomes for the entire duration of this discussion. So number one, we'll be talking about the parasite biology, the pathogenesis and clinical manifestations of this parasite, the diagnosis, the treatment, the epidemiology, and the prevention and control. Okay. All right, so let's talk about the parasite biology. All right, guys. So, Trypanosoma cruzi, it is the etiologic agent of Chagas disease, or American trypanosomiasis, and it was founded by Carlos Chagas way back 100 years ago. So, Carlos Chagas dissected a triatomid bug, and actually he found out that this bug is actually the carrier of this parasite, and it's the same thing with when that child is actually suffering a fever and an enlargement of the lymph nodes of a child. And since then, the understanding behind the disease that is the protozoan can cause or shown that the profound changes in terms of the pathophysiology of this parasite and diagnosis and treatment. So, T. cruzi belongs to the trypanosome group of Stercoraria, and chromosomes under this group multiply within the mammalian host in a discontinuous manner. And unlike other trypanosome, it is an intracellular parasite with myocytes, particularly the myocardial tissue and cells of the reticuloendothelial system. And so most heavily infected cells. So other tissues that get infected include the skin, the gonads, the intestinal mucosa, and the placenta. So it has been well established that this arthropod vector, or I mean vectors, are responsible for the parasites. For this parasite include the triatoma, the Panstrongylus, and the Rodneus. So these arthropods thrive under squalid housing conditions, like such as thatched roofs and mud walls. It is commonly seen in poor rural communities, like especially because this parasite TCRZ was discovered in American regions. So I do believe some of them, we all know that that region, that American region, is part of the first world country. But let's put this in our mind that not all of that region, American region, is actually a first world country. Some of them are might be in the second world or in the third world, especially in those areas or countries belongs to, South America. And this zoonotic mammalian reserva hosts have been identified, including domestic animals like armadillos, raccoons, rodents, marsupials, and even some primates. And T. cruzi exhibits all. So this T. cruzi exhibit all four stages of development. So again, guys, as I've mentioned, that these T. cruzi exhibits all four stages of development. So I do have here the amastigote, the permastigote, the epismastigote, and the trypomastigote. So in humans, trypomastigotes are found in the bloodstream and amastigotes in tissue cells. So amastigotes are round or ovoid in shape and measure from 1.5 to 4 micrometer in diameter. I'm sorry, guys. So they are usually found in small groups of cysts, like collections in tissues. So the long, slender trypomastigotes are 16 to 20 micrometer in length, while the short and stumpy forms measure around 15 micrometer. So the posterior end is usually pointed and the undulating membrane is narrow with two, three undulations and a single thread-like flagellum originating near the kinetoplast provides the parasites with mobility. So in stained specimens, trypomastigotes are characteristically C-shaped. Okay, so again, in stained specimens, trypomastigotes are characteristically C-shaped, and they have also been described as U or S-shaped with a prominent kinetoplast characteristics of species. So right now, I do. So again, guys, right now I do have here, as you can see in our monitor, that I do have here the life cycle of T. cruzi or the Trypanosoma cruzi. So the trypomastigotes of T. cruzi did not multiply in the bloodstream, and soon after their entry into the human host, the metacyclic trypanosomes are engulfed by macrophages of the reticuloendothelial system and multiply through binary fission as amastigotes. So amastigotes develop into the trypomastigotes, and the cells lies in 4 to 5 days. So the release of trypomastigotes enter into the bloodstream of human. So as you can see right now here, so it's ready to replicate again once they enter another cell or are ingested by an insect vector. Once ingested by the intermediate host, the trypomastigotes pass through the posterior position of the insect's midgut and become epimastigotes, and where they multiply via longitudinal fission. So infected metacyclic trypomastigotes appear in the insect's rectum to 8 to 10 days after infection and are passed into the bug's feces. And again, the metacyclic trypomastigotes gain entry into the body through broken skin or through mucous membranes that are rubbed with fingers contaminated with the bog's feces. So other also might be there. Again, as I've told you earlier, it can be in the raccoons or other mammals. So right now we are down to our pathogenesis and clinical manifestations of trypanosoma cruzi. So right now we are down to our pathogenesis and clinical manifestation of this parasite trypanosoma cruzi. So actually, for this, the disease, Chagas disease, can be divided into two phases. Number one is the acute phase and the chronic phase. When we say acute phase, it is characterized by a focal or diffuse inflammation, mainly affecting the myocardium. The chronic phase, on the other hand, it is the multifactorial and dependent on the interaction between parasite and host, manifested by fibrotic reactions that cause injury to the myocardium, cardiac connection network, and enteric nervous system. Again, if someone will gonna ask you what are the two phases of the Chagas disease, always remember that there are only two. One is the acute phase, and the other one is the chronic phase. So when we say the acute phase, so it is the signs and symptoms of this can be fever, malaise, nausea, vomiting, or maybe generalized lymphadeno, lymphadenopathy, often accompanied of this disease, and it can sometimes appear during this phase, which I am actually referring to the acute phase. So if the parasite penetrates through the conjunctiva, conjunctiva, so the eyelid swelling is called Romania. All right. So again, if the parasite penetrates through conjunctiva, the eyelid swelling can be called Romania. So again, what is that eyelid swelling? Always remember, it is what? It is Romania. All right, very good. So, and for the for the chronic phase, so this phase was initially thought to be autoimmune in nature. However, this is controversial. Why? Because the newer evidence shows that chronic Chagas disease is multifactorial and dependent on the interaction between parasite and the host. So nonetheless, the chronic phase is manifested by fibrotic reactions that cause injury to the myocardium and cardiac condenser network, as I have told you earlier. So, if this chronic Chagas disease, so after several years of having this, phase, which is the chronic phase, the majority of the symptomatic or chronic patient manifest with the cardiac form. So, so always remember that in the chronic phase, this parasite could actually be manifested our cardiovascular system. But again, if a well developed this form in or in our cardiac or in our cardiac or cardiovascular system, the rest will develop through gastrointestinal form. So hindi lang sila nag-manifest doon sa myocardium, cardiac conduction, and enteric nervous system. But it could also lead to some um, damage or severe infection to our gastrointestinal. So, di ba? Nakakuan, nakakatsaka na talaga. So, ayan. And lastly, we are now to our diagnosis. All right, guys, for our diagnosis, always remember this we have a complete patient history is a primary tool for diagnosing Chagas disease. And it's direct visualization of the parasite in thick and thin blood smears using Guyam cysteine. Concentration methods or microhematocrit, blood culture, and PCRs in diagnosis. And other diagnostic techniques include enzyme link, immunosorbent assay, immunofluorescent indirect coagulation test, mini anion exchange centrifugation technique, and PCR. So, for this, sir, the definitive diagnosis of Chagas disease during its acute phase relies on the direct visualization of the parasite and a thin blood smear. So that is for the number one. So that's during the acute phase. So cerebrospinal fluid or CSF or tissue samples or lymph can also be used for parasite visualization. However, only in the first 2 months of acute disease can T. cruzi trypomastix be seen by the direct examination. Again, it is just for 2 months that we can see the trypomastix for tricusi during the direct examination. Now for the chronic phase, a variety of serologic tests may be used, such as enzyme-linked immunosorbent assay, or ELISA, or indirect hemagglutination, or indirect immunofluorescent. So here, in the number four, that is that can be used during the the chronic phase. But here, who recommends using at least two techniques with concurrent positive results before a diagnosis of Chagas disease is made? Let's say for the cardiac form of the disease, ECG and echocardiography may show atrial fibrillation or flutter or low QRS voltage, and sometimes dilated cardiomyopathy and tricuspid and mitral regurgitation. So again, once again, that is the different kinds of diagnosis when it comes to the acute phase and the chronic phase. All right.
Now, let's move on to each treatment. As mentioned by the previous reporter in the pathogenesis and clinical manifestation of Trypanosoma cruzi, Chagas disease has two phases. The first one is the acute and the second phase is the chronic ones. Now, during acute phase, the prescription medication includes benzimidazole and efortimox. So, to visualize this medication, as you can see in the picture, that is benzimidazole and the other one is nefartimox. So both drugs are available in the regions that are most affected by Chagas disease. However, these drugs can only be obtained through the Centers for Disease Control and Prevention in United States. Moreover, there are also additional treatments that depends on the specific signs and symptoms. This includes pacemakers and amiodarone hydrochloride for heart-related complications. And it also have treatments for digestive-related complications. And this includes diet changes and laxative medication, as you can see there. So, once Chagas disease reaches the chronic phase, medications won't cure the disease anymore. However, there are some drugs that may be offered to individuals younger than 50 years old because this helps slow the progression of the disease and its most serious complications. Hello there, this is Charisme. Now, as you can see in the image wherein it shows the global distribution of cases of Chagas disease based on official estimates in the year 2006-2010, there are lots of countries that are affected by Chagas disease or American trypanosomiasis. So, you might ask, why does it named American if we can just call it trypanosomiasis itself? Well, to answer that question, there are also other types of trypanosomiasis. One example is human African trypanosomiasis that will be further discussed by my co-reporter after we finish exploring Trypanosoma cruzi. So, going back, let's now focus on the epidemiology of the Chagas disease itself. It is clearly stated in the PPT that Chagas disease is estimated to have infected more than 10 million people worldwide. That's too much. Now next, in 2003, it ranked third as the leading cause of parasitic infection in the world, behind malaria and schistosomiasis. No wonder that Chagas disease remains one of the biggest public health problems according to the World Health Organization. Thus, approximately 10,000 to 12,000 deaths occur per year and most cases are reported in the Latin Americas, where more than 25 million people are at risk for the disease. So, as you can see in the image, there are almost 21 countries across Latin Americans that considered as endemic from this particular disease according to Drugs for Neglecting Diseases Initiative or DNDi. So you might wonder what country has the highest number of Chagas disease infected migrants? Well, it is the United States, and the second highest is the Spain, with an estimated 67,000 affected immigrants. Hence, the prevalence and distribution of American trypanosomiasis has been continually shifting. So, before we proceed to the next slide, one of the nice to know information is that knowing what are those 21 countries that were considered as endemic. So, we have Argentina, Belize, Bolivia, Brazil, Chile, Colombia, Costa Rica, Ecuador, El Salvador, Guatemala, French Guiana, Guyana, Honduras, Mexico, Nicaragua, Panama, Paraguay, Peru, Suriname, Uruguay, and lastly, Venezuela. Now, for the prevention and control, I listed three. We have vector control, blood transfusion control, and mother-child transmission control. Now, first, let's talk about vector control. So, vector control uses synthetic parathyroid insecticides. Through this control, it shows that the incidence statistics indicates that the number of newly infected people every year has decreased drastically. Next, we have blood transfusion control. Donated blood has been tested for Chagas disease since 2007. In addition with that, primary precautionary effort has been through screening blood donations. So this practice has been legally enforced and implemented in almost all endemic countries such as Brazil, Chile, and Uruguay. Lastly, mother-child transmission control is also helpful as this protocol screens pregnant women and children of infected mothers. Now, for the end part, we have the new trends and additional information. So for the first one, it is indeed essential to know the serological approaches for Trypanosoma cruzi strain typing. So, as stated by Virginia Ballows, a researcher, Typing of the infecting strains directly in biological samples may shed new light on Trypanosoma cruzi zoonotic distribution, and more importantly, may facilitate the study of possible associations between parasite genotype and Chagas disease clinical outcome. So, in relation with the second trend, because the first one and the second one has the same studies, that's why they're connected. It also mentioned about serological approaches for strain typing that high throughput immunomics provides a unique opportunity to link the increasing ability to catalog variations among Trypanosoma cruzi genomes to the identification of novel polymorphic targets of strain-specific B cell immunity. Now, let's move on to the third trend. So this focuses more on pharmacological management of Chagas disease according to Vanessa Ribeiro, a researcher. So studies shows that association of benznidazole with other drugs is more efficient than benznidazole alone. Thus, in connection for the fourth and last one, since they both have the same study also, most researchers nowadays focus on the development of new drugs to combat Chagas disease. So, as conclusion, the researchers shows a positive result that the use of benznidazole in combination with other compounds has shown advantages compared to its use alone. And with regards to the fourth um, trend, the search for new pharmacological alternatives has been the most used strategy to find new effective drugs. And this is the end of our report about Trypanosoma cruzi. Again, I am Charisse May T. Kapuyan. Good day.
Good day, everyone. So, I am Reka Q. Vinegas, and my topic for today is Trypanosoma brucei gambiense and Trypanosoma brucei rhodesiense. So, here are the table of contents. We will discuss about the parasite biology, the pathogenesis and clinical manifestation, diagnosis, treatment, epidemiology, and prevention. So, the parasite biology. So, human African trypanosomiasis, or HAT, or also known as African sleeping sickness, is a highly fatal disease caused by the subspecies of Trypanosoma brucei, which are the Trypanosoma brucei gambiense and the Trypanosoma brucei rhodesiense. So these two subspecies of T. brucei is part of the Salivaria family, and the usual transmission of this parasite is the tsetse fly. Also, there is a third subspecies of the Trypanosoma brucei, which is the Trypanosoma brucei, which primarily affects wild and domestic animals. And if these three subspecies are present, they are called Trypanosoma brucei complex. So, Trypanosoma brucei gambiense affects humans primarily, but they also utilizes dogs, pigs, and sheep as their host. So, it is responsible for the chronic type of sleeping sickness and accounts for 95% of all HAT cases. So, these Trypanosoma brucei gambiense is mostly found in the western and central regions of sub-Saharan Africa. Now let's go to the Trypanosoma brucei rhodesiense. So this affects primarily cattle and wild animals, and humans are just an accidental host. So, this causes more acute and rapidly fatal form of sleeping sickness and accounts for the remaining 5% of the HAT cases. And it is mostly found in the East Africa. So, only the epimastigote and the trypomastigote form are exhibit in the Trypanosoma brucei complex. So the epimastigote form is more polymorphic, which has a typically slender form, short and slumpy form. Also, it is flattened and fusiform and has a 14 to 33 micrometer in length and 1.5 to 3.5 micrometer in width. And so, in the tripomastigote form, this changes to a procyclic form which multiplies for about 15 to 20 days, where the epimastigote then matured into metacyclic tripomastigotes. And when these metacyclic tripomastigotes are passed to other hosts, it will then mature there in the blood and the connective tissues. So now the mode of transmission of this Trypanosoma brucei species or this Trypanosoma brucei complex i- is transmitted via insect vector or the blood-sucking tetter fly, um, a mechanical method most likely accidentally being pricked by the contaminated needle or other blood sucking insects. And also, um, these Trypanosoma brucei species can be transmitted via mother to child infection. Let us discuss the life cycle of the African trypanosomiasis. So, firstly, when an infected chichi fly takes on a blood meal to its host, they will then inject the metacyclic trypomastigotes, which is the infectious stage of the African trypanosomiasis, which will then transform or mature into the bloodstream, which will then be carried out to the other sites. So, when these metacyclic tripomastigotes matured, um, they then multiply in the bloodstream by the binary fission in the various body fluids like the blood, the lymph, and the spinal fluid. And then they will circulate in the blood during their acute phase. That is why when they are that is why they are usually undetectable in the latent phase and is very hard to be diagnosed. So, cattle and wild animals are most likely the reservoirs for the Trypanosoma brucei rhodesiense. So, when an infected host is being blood sucked by another non-infective tsetse fly or an insect vector, the trypomastigotes are ingested by that vector and will go to their bloodstream, which will then transform into a procyclic trypomastigotes in the vector's midgut. And then this procyclic trypomastigotes multiplies through binary fission, which will then leave the midguts of the vector and will transform into an epimastigotes, and these epimastigotes will then go to the salivary gland of the vector and will then multiply, which will then transform into a metacyclic trypomastigotes. Then, when they matured in the vector, um, then this infected vector will then infect another host by blood sucking in their host, which will then goes to the back to the first process of the life cycle of the African tryposomiasis. So that's all. That's the life cycle of the African trypanosomiasis.
Good morning, sir. My name is Siti Asmina Yusayutin. So for the continuation, I'm gonna report the pathogenesis, clinical manifestations, and diagnosis of Trypanosoma brucei species. Pathogenesis and the clinical manifestations. Human African trypanosomiasis has two types, the acute and chronic, depending on the subspecies causing the disease. Trypanosoma brucei gabesiense is a sleeping sickness manifests months or years after the initial infections, while the symptoms of Trypanosoma brucei rhodesiense is a sleeping sickness may appear just a weeks after the infections. The initial lesion of African trypanosomiasis begins at local, pruritic, or erythematous shuns located at the bite site, progressing into a scar and resolving 2 to 3 weeks. This trypanosomal shanre is more common in Gambian sleeping sickness. Several days after the development of the shanre, usually within 10 to 3 days, the next stages of the disease manifest. Both types of human African trypanosomiasis undergo two stages, the early and the late. During the early phase of HAT, called hemolymphatic stage, the parasite proliferate in the bloodstream and lymphatic. The patient may manifest with irregular bouts of fever, headache, joint and muscles, and malaise. Anemia, myocardial inflammation, disseminated intravascular coagulation, and renal insufficiency may occur. Frequently in Gambian trypanosomiasis, the posterior cervical lymph nodes are enlarged, non-tender, and rubbery inconsistency or the Winterbottom signs. The signs and symptoms manifest within this space are due to tissue damage, either from the parasite, toxins, or immune complex reaction that target organ the RBC or the red blood cells. The early systemic phase lasts from 1 to 6 months. The second stage is the late phase of the disease, known as the meningoencephalitic stage. It involves the central nervous system. The brain and meninges becomes involved as the parasites find their way into the central nervous system through the bloodstream. Usually occurs 3 to 10 months after the initial infection in Gambian infections, but can manifest after just a few weeks in Rhodesian trypanosomiasis. Neurologic symptoms becomes evidence such as apathy, behavioral changes, headache, and sleep pattern changes. This may be followed by more severe symptoms such as convulsions, tremors, speech defects, disturbances in speech and reflexes, and even paralysis. In the later stage, somnolence manifests, followed by the deep coma. Death eventually follows either from the disease itself or from the intercurrent infections due to immunosuppressions. Autopsy of hat or human African trypanosomiasis patients reveals edema and numerous small and confluent hemorrhage. Diagnosis of Trypanosoma brucei species. Diagnosis of human African trypanosomiasis depends upon the demonstrations of highly motile trypomastigotes in expressed fluids from Ashanre, lymph nodes aspirate, and cerebrospinal fluids. Examination in trypomastigos is usually done during the hemolymphatic stage of the disease. Other diagnostic techniques include the enzyme-linked immunoservant assay, immunofluorescein, indirect hemagglutinin test, mean ion exchange centrifugation technique, and PCR. Cerebrospinal fluid examination is mandatory in a patient with suspected human African trypanosomiasis to detect the central nervous system involvement. Abnormal cerebrospinal fluid increase in a cell count, opening pressure, protein concentration, and IgM levels. The latter is considered pathognomonic for the meningoencephalitic stage of the disease. Card agglutination test for trypanosomiasis is detecting circulating antigens in persons infected with Trypanosomia brucei species complex is available commercially and can be used in the field setting to screen anti-risk population.
Hi, this is Robelyn Poise, and I'm going to discuss about the treatment, epidemiology, control and prevention, and the nutrients. So let us start with the treatment. Anyone diagnosed with African trypanosomiasis should be treated with a specific drug and treatment course depending on type of infection, if it has TB gambiense or TB rhodesiense, and disease stage, for example, if it has a presence or absence of central nervous system involvement. Pentamidine, the recommended drug for first stage TB Gambiense infection, is available in the United States. The other drugs, the soramine, naloxone, eflornithine, and nifortimox, when used in combination with eflornithine, used to treat African trypanosomiasis, are not commercially available in the United States, but can be obtained from CDC. So physicians can consult with the CDC staff to obtain these otherwise unavailable treatment drugs. So there is no test of cure for African trypanosomiasis. After treatment, patients should be closely followed for 24 months and monitored for relapse. Recurrence of symptoms will require examination of body fluids, including CSF or the cerebral spinal fluid, to detect the presence of trypanosomes. For the epidemiology, human African trypanosomiasis, also known as sleeping sickness, is caused by two subspecies of trypanosomes transmitted to man by various subspecies of Glossina, which are the tsetse flies. Trypanosoma brucei gambiense is the etiological agent of Gambian trypanosomiasis, which is prevalent in West and Central Africa, while Trypanosoma brucei rhodesiense is the agent of Rhodesian trypanosomiasis seen in East and Southern Africa. So sleeping sickness was the utmost public health problem of equatorial Africa in the first half of the century. its incidence decreased considerably following massive efforts for case finding and chemoprophylaxis. Resurgence of African trypanosomiasis was documented in the 1990s in several countries where war or civil strife hampered control programs, but renewed investment in its control eventually proved successful. For the whole continent, 11,382 cases of Gambian trypanosomiasis were reported in 2006, compared to only 486 cases of Rhodesian trypanosomiasis. The, the Democratic Republic of Congo, or the DRC, remains the country with the highest incidence of Gambian trypanosomiasis, with 8,023 cases in 2006 from a peak of 26,318 cases in 1998. And in Angola, reported 1,105 cases in 2006 also, compared to 8,275 cases in 1997. And in Sudan, it has 809 cases. And in Uganda has the highest reported incidence of Rhodesian trypanosomiasis, which it has 245 cases in 2006 also. For prevention and control, there is no vaccine or drug for prophylaxis against African trypanosomiasis. Preventive measures are aimed at minimizing contact with tsetse flies. Local residents in endemic countries are usually aware of the areas that are heavily infested and may be able to provide advice about places to avoid. Other helpful measures include wear long-sleeved shirts and pants of medium weight material in a neutral colors that blend with the background environment. Because tsetse flies are attracted to bright or dark colors and they can bite through lightweight clothing. Next is to inspect vehicles before entering. The flies are attracted to the motion and dust from moving vehicles, so you should always inspect vehicles before entering. And avoid bushes because the tsetse fly is less active during the hottest part of the day but will bite if disturbed. Lastly, use insect repellent. Permethrin impregnated clothing and insect repellent have not been proved to be particularly effective against tsetse flies, but they will prevent other insect bites that can cause illness. For the new trend, countries endemic for human African trypanosomiasis or HAT, also known as sleeping sickness, continue to report fewer cases, indicating that the disease is well on course for elimination as a public health problem by the end of this year. However, unlike the past years, the cases have been reportedly continued decreasing, but a case in Malawi, there has been an important increase in the number of cases was reported in the last months of 2019 around Baza Marsh and Onkotakota wildlife reserves, where the diversity of wild animals is considered to be the main potential reservoir of the disease. With that, the World Health Organization are aiming for an elimination of transmission or the zero cases for Gambiense HAT in 2030. World Health Organization provides the anti-trypanosomal medicines free of charge to endemic countries through public to private partnerships. With Sanofi, who has the pentamidine, melarsoprol, eflornithine, and pixinidazole, and with Bayer Healthcare, who has the Soramine and Fortimox. and the medicines are conditioned and shipped in collaboration with MSF Logistics.
Good day, everyone. I am Mark Daniel Lirio, and at this moment, we are going to discuss Leishmania species. So, to start with, Leishmaniasis has a long history dating back as far as the 1st century AD. As early as this period, pre-Incan pottery from Ecuador and Peru displayed depictions of skin lesions and facial deformities that are typical of cutaneous and mucocutaneous leishmaniasis. Early descriptions of leishmaniasis have been found as early as the 1st century AD, and American Indians documented the disease in pottery figures. And Cunningham studied the Delhi boil in India back in 1885. Next, Leishmania brasiliensis was later identified in 1911 by Gaspar Viana, and in 1922 Henrique Aragao discovered that it was the insect vector which transmitted this parasite. To further discuss, leishmaniasis is a vector-borne disease caused by infection of the diploid protozoa belonging to the genus Leishmania. They are transmitted through insects popularly known as sandflies or infected by the female phlebotomine sandflies. So, just like the dengue, diba, which is ang naga-infect is a female Aedes mosquito. The same goes with this parasite, Leishmania. It is transmitted by insects popularly known as the female phlebotomine sandflies. Furthermore, leishmaniasis is a parasitic disease that is found mostly in parts of the tropics, subtropics, and southern Europe. Leishmaniasis is caused by infection with Leishmania parasites, which are spread by the bite of infected sandflies. So, this can cause different clinical presentations from cutaneous and or mucosal lesions, the tegumentary leishmaniasis, up to visceral infection with tropism by the lymphohematopoietic system or the visceral leishmaniasis. The term leishmaniasis encompasses multiple clinical syndromes, several of which are described as the cutaneous, mucosal, and visceral forms, which result from infection of macrophages in the dermis, in the nasopharyngeal mucosa, and throughout the reticuloendothelial system, respectively. For all three forms, the infection can range from asymptomatic to severe. Cutaneous and mucosal leishmaniasis can cause substantial morbidity, where visceral leishmaniasis can be life-threatening. And these three forms will be discussed later on. But now, let's proceed to the classification of leishmaniasis. So, referring to the book of Zabig, the classification of the parasites, the hemoflagellates are the Leishmania species from the subphylum Mastigophora, from the class Zoomastigophora, and here the blood tissue species. This includes the Leishmania brasiliensis complex, the Leishmania donovani complex, the Leishmania mexicana complex, the Leishmania tropica complex, Also, we have the Trypanosoma brucei gabiense, the Trypanosoma brucei rhodesiense, the Trypanosoma cruzi, and the Trypanosoma rangilii. Next, epidemiologically, the Leishmania species are divided into two subgenera, the Phlebotomus, or the Old World, and Lutzumia, or the New World. Take note that if we say epidemiologically, it refers to the location where a certain parasite is prevalent, while if when we say morphologically, it is referring to the structure of the parasite. So going back, Phlebotomus and Lutzomia sandfly bites transmit leishmaniasis to humans in most of the tropical and subtropical world. So meaning to say that we are talking about here the location or the region where this leishmania species are mostly in common or prevalent. So in old world leishmaniasis, the most common species are Leishmania tropica, Leishmania ethiopica, and we have Leishmania major. So these Leishmania species are most common in Asia, in Eastern Europe, and in some parts of Africa. While in the New World Leishmaniasis naman, the most common Leishmania species are Leishmania mexicana, Leishmania amazonensis, Leishmania guyanensis, the Leishmania brasiliensis, and Leishmania chagasi. So these Leishmania species affects Mexico, Central America, and some parts of South America and Amazon rains. Aside from that, take note that dogs are the primary reservoir in urban areas, as well as rodents. They also act as reservoirs host in both urban and rural areas. And at this juncture, let us now proceed to the morphology of Leishmania species. So there are two morphology involved in this parasite, the promastigote and a mastigote. So promastigote morphology in the sandflies or extracellular, and a mastigote morphology in the mammalian host or intracellular. So promastigotes has long motile flagellum. Looking at the picture, it is the tail end like the form of the promastigotes. Its size range is from 15 to 20 micrometer in length and 1.5 to 3.5 micrometer in width. But referring to the book of Zeybig, the size of the promastigote ranges from 9 to 15 micrometer long. However, let's base the size range to the book of Doc Belisario. Next is the shape. It is long and slender. The nucleus, it is one located in or near the center. And these promastigotes invade the cells of the reticuloendothelial system and transform into amastigotes, multiply via binary fission, then migrate to the foregut. Later on, we will discuss its life cycle, which includes this one. But let's have first proceed to the amastigotes. So, amastigotes has short immotile flagellum. So, as compared sa promastigote, di ba? mas taas ang flagellum as compared to this one. Then, on the size range, it's 2 to 3 micrometer in length. So, mas gamay siya as compare sa kay promastigote. And then the shape, it's ovoid or rounded bodies. And the nucleus is one, usually off-center, large, while an axoneme arises from the kinetoplast and extends to the anterior tip. So as you can see in the picture, di ba? And live intracellularly in monocytes, polymorphonuclear leukocytes, or endothelial cells. And remember that both the promastigote and the amastigote forms of leishmania can initiate infections. When infections are initiated with promastigotes, these parasites transform within PVs into amastigotes over a period of 24 to 72 hours. And take note that after this, in effect in infected cells and infected hosts, the infections are sustained by the amastigote forms. So now, let's talk about the life cycle of Leishmania species. So the life cycle of this parasite starts with the sandflies inject the infective stage, for instance the promastigotes, from their proboscis during blood meals. Then, the promastigotes that reach the puncture wound are phagocytized by macrophages, meaning to say that they are being ingested by macrophages and other types of mononuclear phagocytic cells. Promastigotes transform in these cells into the tissue stage of the parasite, or it is transformed into amastigotes, which then multiply through binary fission and proceed to infect other mononuclear phagocytic cells. Parasite, host, and other factors affect whether the infection becomes symptomatic and whether cutaneous or visceral leishmaniasis results. Sandflies become infected by ingesting infected cells during blood meals. In sandflies, amastigotes transform into promastigotes develop in the gut or in the hindgut for leishmanial organisms in the Viania subgenus, or in the midgut for organisms in the Leishmania subgenus. And then they migrate to the proboscis. Also, on the next picture, as you can see that the infected person or animals such as the rodents, the dogs, and the foxes infected by the sandfly, and then the sandfly will bite the another person, and that causes the another person to be infected by this type of parasite. So it is very the life cycle of Leishmania species goes on and on.
Good day, everyone. My name is Marian Rose Gokong. Today, I will be discussing the pathogenesis, clinical manifestations, and the diagnostic test in leishmaniasis. Pathogenesis and clinical manifestation of leishmaniasis. The wide spectrum of symptoms manifested by leishmaniasis is often compared to leprosy, or a chronic disease that also affects the skin of a person, where the localized cutaneous leishmaniasis is similar to tuberculoid leprosy, and the diffuse cutaneous leishmaniasis is similar to lepromatous leprosy. Tuberculoid leprosy and lepromatous leprosy are the two major types of leprosy. The extent and presentation of disease depend on several factors, including the humoral and cell-mediated immune response of the host when infected by this kind of disease. Cutaneous leishmaniasis is an erythematous papule or nodule called an oriental button or lesions. The most common form of the disease is caused by the several species of Leishmania, including L. tropica, L. major, and L. mexicana. Although cutaneous leishmaniasis is not life-threatening, it can have devastating effects on local communities. When a person is infected, the incubation period ranges from 2 weeks to several months, and while the lesion may heal spontaneously after a few months, it will leave a disfiguring scar onto a person's body. Diffuse cutaneous leishmaniasis is also called an allergic or lepropathous leishmaniasis, characterized by a localized non-ulcerating papule. It is a rare form of leishmaniasis where parasites grow uncontrolled in diffuse lesions across the skin. Mucocutaneous leishmaniasis develops in about 2 to 5% of persons infected with L. brasiliensis, either concurrently or even several years after the resolution of skin lesions. It may also due to the contagious spread of cutaneous leishmaniasis caused by L. tropica. In mucocutaneous leishmaniasis, the lesions can lead to partial or total destruction of the mucous membranes of the nose, mouth, and throat cavities and surrounding tissues of a person infected with it. Visceral leishmaniasis or Kala-Azar is a disseminated parasitosis primarily caused by L. donovani complex, L. chagassi, and L. infantum. This manifestation of the disease stems from the spread of parasites into the bone marrow, spleen, and liver. When a person is infected, it has an incubation period of 2 to 8 months, and it is one of the most severe form of leishmaniasis and a life-threatening one disease. Here we have diagnosis or the diagnostic test to be performed when you are infected with leishmaniasis. First, we have demonstration of a mastigotes or a definitive diagnosis of leishmaniasis rests on the microscopic detection of a mastigotes in tissue specimen or isolation of the organism by culture. Next, we have the Leishmanin skin test or also called Montenegro test is an immunologic skin test that measures delayed type hypersensitivity to Leishmania antigen. It can be used as a diagnosis of cutaneous leishmaniasis also. And lastly, we have PCR or polymerase chain reaction.
What are the treatments for leishmaniasis? Before considering treatment, the first step is to make sure the diagnosis is correct. Antiparasitic drugs such as amphotericin B, sodium stibogluconate, liposomal amphotericin B, and paramomycin and miltepocin can treat this condition. Your doctor may recommend other treatments based on the type of leishmaniasis you have. The epidemiology of leishmaniasis. Leishmaniasis is found in people in focal areas of approximately 90 countries in the tropics, subtropics, and southern Europe. Leishmaniasis usually is more common in rural than in urban areas, but it is found in the outskirts of some cities. Climate and other environmental changes have the potential to expand the geographic range of the sandfly vectors and the areas in the world where leishmaniasis is found. Leishmaniasis is found in people on every continent except Australia and Antarctica. Prevention and control for leishmaniasis. How can you prevent leishmaniasis? There is no vaccine or prophylactic medication available. The only way to prevent leishmaniasis is to avoid getting bitten by a sandfly. Here are the steps to help prevent being bitten by a sandfly. Wear clothing that covers as much skin as possible. Long pants, long sleeve shirts tucked into pants, and high socks are recommended. Use insect repellent on any exposed skin on the ends of your pants and sleeves. The most effective insect repellents contain DEET. Spray indoor sleeping areas with insecticide. Sleep on the higher floors of a building. The insects are poor flyers. Avoid the outdoors between dusk and dawn. This is when sandflies are most active. Use screens and air conditioning indoors when possible. Using fans might make it more difficult for the insects to fly. Use a bed net tucked into your mattress. Sandflies are much smaller than mosquitoes, so you need a tightly woven net. Spray the net with insecticide containing pyrethroid if possible. Buy bed nets, insecticide, and repellents before traveling to a high-risk areas. The new trends for leishmaniasis. Viable leishmania parasites have already been found in semen, with a high parasite load in the prepuce, glans penis, epididymis, testes, and prostate of male symptomatic dogs, and to a lesser extent in asymptomatic dogs. A case of potential male-to-female sexual transmission in dogs was reported in Germany, a non-endemic country for visceral leishmaniasis. In a Brazilian study, 6 of 12 visceral leishmaniasis negative female dogs became PCR positive for leishmania after sexual contact with seropositive male dogs with PCR positive semen. The first person of presumed sexual transmission of leishmania in humans was published in 1960.
What have you learned today? Let's check your knowledge. Please note, you only have 10 seconds to answer each question. Good luck. Is the etiologic agent of Chagas disease or American trypanosomiasis? Time's up. The correct answer is letter A, Trypanosoma cruzi. These are the treatment of Leishmania species except time's up. The correct answer is letter D, eflornithine. Is responsible for the chronic type of sleeping sickness and accounts for 95% of all head cases. Time's up. The correct answer is letter C, Trypanosoma brucei. It causes more acute and rapidly fatal form of sleeping sickness and accounts for the remaining 5% of head cases. Time's up. The correct answer is letter A, Trypanosoma brucei. In the chronic phase of Trypanosoma cruzi, it is multifactorial and dependent on the interaction between parasite and host. It is characterized by focal or diffuse inflammation mainly affecting the myocardium. Time's up. The correct answer is letter A. The first statement is correct. Arthropod vectors responsible for this parasite include teratoma, Pentringillus, and Rudneus. Time's up. The correct answer is letter B, Trypanosoma cruzi. Who founded the Trypanosoma cruzi? Time's up. The correct answer is letter A, Carlos Chagas. The manifestation of DCL, also called anergic oliprophatus leishmaniasis, characterized by a localized, non-ulcerating papule, eventually developing numerous diffuse satellite lesions that affect the face and extremities. Time's up. The correct answer is letter C. Both statements are correct. Is a disseminated parasitosis primarily caused by L. donovani complex, L. chagassi, and L. infantum. This manifestation of the disease stems from the spread of parasites into the bone marrow, heart, and large intestine. Time's up. The correct answer is letter A. The first statement is correct. These are the treatment for Trypanosoma brucigambans and Trypanosoma brucirrhodiensis, except. Time's up. The correct answer is letter C. Triazole derivatives. I hope you have learned something today. God bless you. Goodbye. Shoes on, get up in the morning, cup of milk, let's rock and roll. Kink out, kick the drum, rolling on like a rolling stone. Sing song when I'm walking home, jump up to the top of the brown. Ding dong, call me on my phone, nice tea, and I'll get my ping pong. This is